Hi, my name is Laura Merson. I'm the head of data at ISARIC, the International Severe Acute Respiratory and Emerging Infections Consortium, and it's really a pleasure to be included in this forum today, and thank you so much for watching this talk. What I'd like to tell you about is our initiative to change the paradigm of how research is done in emerging infections. Now, this is something that was begun more than 10 years ago, following the recognition that the clinical research response to the H1N1 pandemic back in 2009 was completely insufficient. And the parallel recognition that global changes in urbanization and deforestation, travel, migration, trade, were all going to fuel more, larger, and faster spreading emerging infectious disease outbreaks. And therefore, a coalition of the willing came together under the vision that we had to create a global, collaborative, patient-oriented research network that could operate between epidemics and during epidemics to generate new knowledge, maximize the availability of clinical information, and ultimately reduce the impact of future epidemics. And so the approach that we decided to take was, first of all, to prepare standardized protocols, to have discussions about what questions were most critical to answer, and build case report forms that could collect data on them. We also worked on having pre-approved protocols in place in a huge network of sites globally so that those sites were ready for whatever unknown new virus or outbreak was going to hit. We also worked very collaboratively, and not just when those outbreaks did happen, but between the pandemics, to make sure that we could build up trust. We integrated clinical research into the public health response and shared the resources, tools, and lessons learned across each of the initiatives that we worked on together so that we could build this network ready for a response. Now, a key tool in our arsenal was what we call the Clinical Characterization Protocol. This was developed in collaboration with the World Health Organization, and it was designed to inform the key questions of infectious disease outbreaks on transmission and natural history and the mechanisms of severity and how we can influence them. So we developed case report forms, a protocol, data systems, and tools and resources that were ready to respond to any type of emerging infection. We designed the protocol with a tiered approach so that it could be implemented in the most resource appropriate way in any different setting wherever emerging infections occur. And then we shared this with our community so that people could use it in all sorts of different outbreaks that happened around the world. Now, the initial implementations between 2012 and 2019 were in the context of Middle Eastern Respiratory Syndrome, where this protocol was rolled out by the Saudi Arabian Society of Clinical Trials. Additionally, it was rolled out across the United Kingdom as a national priority protocol for pathogens of public health importance. So collecting data on all sorts of cases and outbreaks that emerged within the UK. It was also rolled out within the context of the West African Ebola outbreak to collect observational clinical data and also to implement clinical trials. Within the Zika outbreak, this was shared across networks that were implementing observational studies to understand the impact of Zika, and also as a protocol called Sprint SARI, which was a point prevalence study, meaning this protocol was approved and operationalized in a large number of centers internationally, but activated just 1 week a year so that the staff could retain operationalization of the protocol and be able to roll it out quickly when something emerged. We took all of the lessons learned from the implementation of this protocol within these different contexts, and we built that into the adaptation that we initiated in January 2020 in response to the emerge of SARS-CoV-2. So all of those different contexts and groups who had used this protocol, we took the feedback that they had given us and the new versions that they had developed of all the different tools and created a toolkit that could be rolled out internationally for SARS-CoV-2. That included different versions of consent forms and case report form completion guides that, again, had contributions from around the world. We made sure that the data forms were flexible And we made them modular so that there was the basic module that everybody would complete, and then additional modules which might be more or less relevant to different contexts or patient populations, or you may have different resource levels of staff available to be able to complete those at different times. We built data capture systems for sites who didn't have their own data management system so that we could host the data in a single place for those who needed that support. We also produced a data governance system to make sure that those data could be utilized efficiently and we could produce the most evidence possible. Lastly, for those who didn't use the case report forms and tools that we had developed, we worked on data curation so we could map together the very disparate data that was being contributed from various sites around the world. So harmonizing units and languages and clinical definitions so that we could execute analyses more efficiently. To date, that platform and that collaboration holds data on more than 710,000 hospitalized individuals with COVID-19. That's across 60 different countries, and more than half of those individuals are recruited from countries in low and middle income settings. But the collection of data is not the success of this initiative. It's really how we use those data and what we've done with them. So I'll give you two examples of the regional and network responses that have occurred. Within the UK, this protocol was rolled out across 308 sites, and there's to date actually more than 250,000 patients from the UK who have had data collected under this framework. And those were the data that were fed in through real-time reporting and analysis to the chief medical officers, the scientific advisory group for emergencies who are advising the government on how to form public health policy, and the Office for National Statistics, and also the different modeling groups. And there were reports that were updated every half hour for the government as cases built, so we could have a real-time understanding of how this epidemic was emerging. We supported a similar approach within South Africa, where the National Institute for Communicable Diseases were aggregating all of the data from hospitalized patients across South Africa. Again, these were fed into a central reporting system that could inform government decision and public health policy. We've since worked with NICD to develop a very in-depth characterization of patients who are hospitalized with COVID, and also on a long COVID protocol. To ensure that we maximize the outputs of these data, we also performed centralized analyses and published these in reports starting in March 2020. So we began with weekly reports that would show aggregate results of all of the data that was coming in from around the world. We then put those data onto a publicly available dashboard so that clinicians and public health officials could see what was happening within their regions and compare it across the various countries that were participating in the ISARIC collaboration. Another way that we're making sure that these data get used as much as possible is we have what's called a partner analysis scheme. And under this scheme, anyone who contributes data to the ISARIC partnership can then access the entirety of the data set to execute an analysis that they have envisaged. We take a very collaborative approach to all of these analyses, ensuring equity by involving low and middle income country investigators as well as high income country investigators to make sure that those who have fewer resources to execute the analyses get the tools that they need to be able to participate. There have been more than 20 questions asked of this group, doing in-depth analyses on things like acute kidney injury and thrombosis and neurological impacts of COVID. So taking a very international approach and collaborative approach to answering the questions under the expertise of those who have them. And lastly, to maximize impact, we enabled data use by sharing the data to external researchers. So we've constructed a data sharing platform where there's an inventory of the volumes and types of data that we have available. Researchers can go onto that inventory and understand if the data are there to answer the specific question that they have in mind, or to help them to innovate around what questions could be answered. Researchers would then complete a data access application to request access to the data, and that gets reviewed by our data access committee. Those that are approved will sign a data transfer agreement before transferring anonymized data sets to the researchers to execute that research. And importantly, we've built into this system a means of accrediting the original researchers who collected the data, the frontline healthcare workers who filled out those forms and did all of the data entry. And we've done that by assigning DOIs, or digital object identifiers, to each of the data sets that get cited in publications which use those data. Then we associate the ORC IDs and the credit taxonomy roles of each of those data generators with that DOI, creating the ability to drive metrics and account for how many times your data are reused. Now, in developing this, there have been a huge number of challenges, including meeting the requirements of various privacy regulations, the different types of ethics approvals that all these different sites needed. There's been a lot of politics and bureaucracy about what information could and could not be made available at different times. We've really thought hard about making an equitable data governance framework, and also equitable data collection that demonstrates the diversity of places and regions impacted by COVID, as well as populations. We've tried to work well with other registries, but acknowledge that perhaps working in parallel was also a good thing, because different networks can access different types of contributors. We've also had to cope with our willingness to be flexible with all the added workload that comes with it. And then lastly, there's issues of contracts and data collection fatigue. We've also had problems with data quality, trying to harness data out of electronic health records, and also harmonize disparate data definitions across the different languages and sites. But really building the trust that is needed for sites to work with and share and participate with others around the world has also been a challenge. The solutions to these are few and widely applicable, and that's to bring in the expertise and individuals who know these areas and can manage the things that not all of us are as good at, be it privacy regulations or contracts or data cleaning. Second of all, preparation. So the work that we did over the last 10 years really helped to get us ready for having the forms, trying things out in different contexts, and also having solutions ready for these problems. Being flexible was absolutely critical to ensuring that this study could roll out internationally. And of course, having patience and making sure that we understood the concerns of all of the different sites involved, and knowing what it was that they wanted to get out of their participation and what's important to their patients and in their local context. We helped resolve that by really implementing a collaborative and participatory approach to inputting into what data we're collecting, making sure that we chose the right questions that we needed to ask, and then also in making sure that everyone can participate in the use and analysis of these data. And lastly, data curation was one of our critical tools in being able to tease out the different, again, languages and definitions that we were being submitted. So lastly, we have an impact that's yet to be determined, but I look forward to the answers that this forum will bring forward about how we can achieve the greatest health impact with the available data set, how we can accelerate the capture, curation, or analytic pathways to generate better evidence faster, and also what other types of data we should integrate to be able to answer new questions. And I hope that the CureID community will be a part of answering those. Thanks so much for your time. Bye.